Thank you for the presentation and thank you for inviting me to come here. I'm very excited to talk about this topic, which in my opinion is a little bit overseen, at least from a research point of view in MS. So I'm going to talk to you a little bit about aging in MS, which I will try to provide some evidence that it's two processes causing synergistic deleterious or negative effects on physical function. As Ulrik, I also have a background as an exercise physiologist, so if you have other views on what I'm arguing for, please just comment or save the questions for after. But aging in MS, research on that topic has actually increased within the last 2 decades, but still it lacks a little bit momentum, I think, at least when you compare to other areas in research, in other research areas. So, but overall, there is an overlap in the symptoms you actually see or observe, and that's particularly evident in physical function, or in this case on walking ability. And one argument for that is it's particularly the lower extremity that seems to be affected. And one argument could be that the number of plaques that are present in the nervous system, it's much higher when the disease evolves for the muscles or the nerves that actually innervates and controls, activates our lower extremities. And this is one of the last papers Kurzke made before he passed away. But I actually like the concept that you have a normal person or no plaques, nothing affecting the upper extremity, nothing affecting the lower extremity, and then when the number of plaques starts to increase as the disease increases, well, the lower extremity becomes much more affected because the number of plaques you have to pass with the electrical signals is much higher in the lower extremities versus the upper extremities. That could be one argument why the lower extremities are more affected. But one thing about mobility is that it's associated with the disability progression in MS. But also I think a rather important thing is that it's in several studies it's been perceived or reported to be one of the most important bodily functions. So MS patients themselves rate it as a highly important functional ability, and I think that makes perfect sense. But if you just look at I'm going to show you a little bit about the general population, healthy controls, but also about how it looks in MS. And if you look at the general population, this is a Danish study some years ago, but it could just as well be a Swedish or a Norwegian study or a European study. It's a worldwide phenomenon that you see that there is a graying of the societies, because there is a demographic change at the moment that when you look at the number of females and males, and you have age on this axis here, you can see by the next 30 years or so, there is going to be a high number of people aged 65 and more. So I think when this study came out, and until 2050, the number of people aged 65 years and above is going to be doubled. And the number of people 80 years and above is going to be tripled. And normally these are the persons who go to the hospitals. So that's the general thing. So I think the healthcare systems is going to change dramatically in the coming decades because of this demographic change, because it's going to cost a lot of money. I'm sorry to say that. That's probably how it's going to be, unless the governments or the. Yeah. I know. There are fewer people working. That's an issue, and so fewer people pay taxes, and more people on pension or whatever. So it's going to be an issue, that's for sure. How it's going to be, nobody really knows. But that's just how the demographic changes it looks like in the healthy population. In MS, we don't have that much data actually. But back in 2000, this American US-based study on 2,000 patients, they reported that approximately 9% were 65 years and above. Then a UK-based study, as well as a Danish study from the Danish MS Register, they actually showed that in the UK-based, at least 1/3 were above 60 years, but the same number is actually shown in the Danish population. And so this, I would bet my money that it's the same picture in Sweden. But the challenge is here. There are very little research on this area, on this group of MS patients. And this proportion and number will likely increase due to the demographic changes that is going to happen in the next couple of decades. So I think it is an area we need to also target. I fully agree with you, like early exercise, very important, but this is a present challenge that is going to be more present in the next decades. So why is it relevant to study these older persons with MS? Well, you have the individual perspective, of course. High disability is normally associated with a low quality of life. That's not surprising. And that's shown in this review paper by Giovannoni, and they show that in different age groups with MS, and this is the healthy population and MS, you can see that the quality of life index here, it declines. It's not surprising. That's what we've seen. So that's the individual perspective. As you grow older, you rate your quality of life worse. One other thing is the societal perspective. You have a high disability. You also have high healthcare costs. There's a recent big European study by Kobel and colleagues. They tried to calculate how many expenses you actually had by MS patients in both in the disease-modifying treatments, rehab, and so on. You actually saw a picture like this. Euros, that's per year per patient. Okay? So it's almost a doubling in the number of costs for MS patients as they grow older, and as, of course, their disability progresses. So it's going to cost more money unless the system changes, of course. So I think these two aspects are important, the individual perspective, but also the societal perspective. So that's why this topic is relevant to actually look at, but also in the physical function in particular. This is based on this large US study where they examined these 2,000 patients. They used this SF-12, which is a self-reported questionnaire where you can divide it into a physical component and a cognitive component score. What you can actually see in the different age groups, the younger parts and the older ones down here, you can see that the physical component, it just declined. But the mental component, the self-reported mental component, actually were pretty much stable. So it looks like this is an argument that the physical component is much more deteriorating than the cognitive component. Not to say that the cognitive cannot be a problem. But this is one aspect just showing that. And this, of course, it is associated with the severity of disability. Those who had almost no symptoms, they had a higher score in the physical self-reported quality of life. But those who were more severely affected, bedridden or using wheelchairs, they had a much lower score. And again, this was almost not affected on the mental part. And this has been comparable, some similar findings has been shown in other studies as well. So it looks like that the physical function in particular are affected, and that's rated by the participants themselves. So I'm just going to use this framework here just to go through some different reasons why this could be a problem and why there probably is a combined negative effect of aging and MS. We don't know that yet, but we have some indications that it goes that way. So you could have a lot of extra and intra-individual factors. It could be diet and so on, environment, latitude, how much sun you get each year and so on. I'm not going to take that into account because that's going to be too big a question. But I'm going to go through some pathology, impairments, limitations, and to some extent disability. And this builds on this traditional pathway to disability framework that's been used in aging research a lot. But when you look at pathology, you can see that there's a lot of changes, structure and function of specific tissues, brain tissue, neural tissue, muscle tissue, and so on. And in MS, one of the most prominent things is the brain size. You can see that there's brain atrophy going on. The other one is when you go down to the step on impairments, that's more how the system works, the neuromuscular function. So how strong you are, how good a motor control or muscle control or balance, coordination you have. So that could be muscle strength. And then we go to limitations, a little bit bigger perspective. That's more the physical function, the integrative system. That could be walking ability. And then the last one is more the disability level, or the activity limitations, or how you can participate in the society. That becomes restricted. And of course that's where the problem is. So the pathology can actually drive impairments, that could drive limitations, that could drive that you actually have disabilities. That's the pathway. So I'm going to go through different steps in this part here. But just briefly, this is just the different categories. It's always difficult to categorize people into age groups, because that's also shifting and people can be different. But normally you say that you could have a young group below 44. So this is the MS patients, that's the colors I'm going to use. The red ones and the blue ones is the health controls. We don't really know anything at the pathology level that much about the older MS patients. But I bet there's a million of scans out there. But it's not been dug out. I haven't been able to find it, at least. When we look at, and that's the same for impairments or the neuromuscular system, when we look at physical function and disability, there's a little bit more, but still, it's rather few studies that's actually available out there. So based on that, I'm going to try to deduce something about what we can see in MS versus healthy in the younger and middle-aged groups, but also from the literature or data we have from the aging perspective in the healthy population. Because there are some similarities. Different mechanisms, but there are some similarities. So I'm going to start on the pathology part, where you look at structure or function of the tissues. Just to have a model of that, we have the more upper motor neuron part and the lower motor neuron part here. The brain, or the spinal cord, and the muscles down here. If we just take one of the most obvious things in MS, brain volume, that's being evaluated in almost entirely all MS patients. You have this same picture as Ulrik also showed. You have this normal decline that the orange part here, that's the in this case the untreated MS patients, and the green one, that's how the healthy population will actually develop. So everybody, we will all experience brain atrophy, unfortunately, but it's just accelerated in MS patients. And then the disease-modifying treatments that can reduce the loss, but it cannot normalize it yet. Perhaps in the future, hopefully. But it cannot normalize it. And if you just look at the annualized, it's approximately twice as big in MS patients versus the healthy population. And actually, but if you look at the healthy population, you actually also see a shift, that the older you get, the greater the decline. So that's why if you just see the green line here, it just changes a little bit. So the older you get, the steeper it actually gets. And I'll try to produce some arguments that I don't think it's going to be a linear decline. And it's not a linear decline in MS patients either. It's just to visualize it. I think it is. So I think if you produce enough data, you're going to see that it's a more curvilinear or accelerated decline. So, one area here, if you look at the specific regions as well, not just the whole brain, but also specific regions that's specifically related or associated with motor function. That is the thalamus. In this case here, you see the healthy controls. When you scan them from 41 years in this study and 5 years, you can see there is a gradual decline, not much. And if you look at MS patients, approximately the same age, you see a much steeper decline. So the decline is approximately 2.5 times bigger or greater in MS patients. So it's a little bit the same as the whole brain volume. So this could be an argument that the physical function deteriorates. If we look at the healthy population, we know from these large epidemiological studies, in this case, this is a Dutch study where they've scanned more than 5,000 persons at different ages, and you can see that they've put in these trend lines. So the men and the women from the age of 50 approximately, the brain volume starts to decline. And it's a curvilinear it's a curvilinear trend. So the brain loss becomes bigger and bigger and bigger. But what you can also see, of course, there's a huge variability. And I think that's the same you see in MS, if you look at the absolute values. But that's the trend line in this large study here. So it's a pretty robust study, I think. They have a lot of scans in this. So that's the whole brain volume in the healthy population. If you look at the specific regions from the same study, they've looked at the frontal lobe, the area where the motor cortex is positioned, and you actually see the same type of trend, the same type of decline. And there are other studies actually showing this type of decline, not just from this study. Yeah?
It's lower for the men than for the women. Why? Why?
Unfortunately, I actually have this one. It actually looks like that the deterioration is occurring at an earlier point in men than in women. But actually, I heard this aging researcher some years ago. He always had this analog that he said that men were designed like poor cars, not Volvo. That's a good car, like a Skoda or something like that, or and it was just built to just reproduce, and then that's it. But the women were built like a good car, so they were built to maintain life and actually take care of their outcomes for until a long time. So they were more the Volvo part.
Can it be smoking and drinking?
They took that into account in all this. Yeah, all the lifestyle factors, physical activity, smoking, diet. They tried to take it into account at least. So yeah, but yes, normally there's if you talk about inequality, that's also a topic that men actually doesn't live as long as females. That's another discussion, I think. But what they could see that the frontal lobe was the earliest brain area that were actually affected in both men and women. So it looks like that the motor cortex area is the one that starts to deteriorate the earliest. Another thing here, if you go a little bit further down into spinal cord, you looked at MS, young, middle-aged, and old. This is a post-mortem study, so this is a cadaver analysis. So the people had died of different causes in MS and in healthy population, and then they looked at the number of neurons in the lumbar part of the neurons, but also the thoracic part. But what they could see that the alpha motor neurons were reduced to a high extent in MS patients versus healthy controls, as were the gamma motor neurons. So both vital neurons that is helping us to control our muscles were reduced by approximately 50 to 80%. But of course, this is only a small number of participants. It's very difficult actually to do this cadaver or post-mortem analysis. A classic study in aging research is this one. There's actually 3 classic studies that came out approximately at the same time. They did the same. They quantified the number of neurons across the lifespan in people who had disease of different causes, car accidents, a lot of them, where it was not related to disease. And they could actually see from 10 to 60 years, they had a pretty stable number of motor neurons. But from the age of 60, it started to decline. And it actually looked like that at the age of 80, it was reduced by 30 to 50%. But so not as reduced as the MS versus healthy controls, but still you could see a reduction in the number of neurons. So a little bit, again, a parallel observation in MS. So what Ulrik also mentioned is that when you go to the neuromuscular function, you could also see that the surface EMG, that's also an index of how well your nervous system actually works. If you could roughly say that. It's an index of how many motor units you can recruit and activate at an optimal firing frequency. And it's, as Ulrik also showed, it's approximately 50% reduced in MS versus healthy controls. But still, this is in people below 60 still. Remember that. That's more the average values we have. If we look at young versus old, that's 69 years old and 22-year-old, you also see an approximately 50% reduction. So aging itself from young in the 20s to the 60s, 70s is also reduced to a high extent. And there's a lot of studies actually showing that trend as well. So there may be some of the pathology stuff. It actually looks like it is aligned with what you see in the neuromuscular function. And we actually have some data. We are currently doing a study, cross-sectional study in young, middle-aged and older healthy controls and MS patients, trying to look at how it affects the neuromuscular system and the physical function. What we could actually see that in the healthy population, you see a pretty stable phase from young to middle-aged, which from then on decreased by in this case 50%. And when we looked at the MS patients, it was more some sort of a gradual decline all the time, and that's probably due to the disease activity going on here. So this is the EMG output to the muscles that is deteriorating. And then the next step, now we have the nervous system that's being affected or deteriorating in a number of pathology. How does it actually innervate and activate the muscles? Well, you normally see that the nerve fibers branches out and innervates the muscle fibers, like in a pattern like this. So this is in young adulthood, in this case here, in aging, and you see a cross-sectional area of the muscle fibers. So you've just sliced the muscles across here, and you can see that the muscle fibers have different sizes. And you can actually, if there are small damages going on, you can continuously repair that. So you still have your repair mechanisms going on. When you go to the older groups in 60s, start 70s, well, it looks like that you actually are not that able to actually repair some of the nerve branches if they're damaged. But luckily you have some of the more functioning nerve branches, they can re-innervate. So they can sprout, build out a new branch of the nerve fiber and re-innervate some of the muscle fibers. So actually you don't lose that much muscle mass and you don't lose number of muscle fibers, but you get a change in your fiber type composition. And then you have the very old people, above 70, 80 years and above. You actually both lose the repair ability, but also the re-innervation ability. So you cannot repair the damaged branches, and you cannot re-innervate that much anymore. So if you can see the pictures here, the muscle size starts to decline, and here you can see a much more clearly picture that the muscle fibers itself are starting to become much smaller. And there's been no studies in this actually in MS, but I would actually assume that this is going to be a little bit the same picture. So this could be relapse remitting. You still have some ability to do some repair, and then when the disease continues or it goes into secondary or if you have progressive MS, I think some of these inabilities to repair or re-innovate will start to go on. And I don't have any studies on the neuromuscular synapses or branches, but it looks like from animal studies and so on, it looks like that you see some of these inabilities in the CNS. So it looks like that in the brain, in different animal studies, you actually do detect this loss of repair mechanisms as the disease actually continues. So it looks again like there's some sort of a parallel in MS and in the healthy population. So in terms of functionality, muscle fiber size, the motor unit size, it can both decline, but it can also increase. If the motor unit size is declined, that's because you lose nerve branches and the muscles die away. But it can also, the muscle unit size, that is the nerve and the number of fibers that actually innervates, that normally increases if you have re-innervation. And if that happens, then your fine motor control will be reduced. So if you only have one nerve and you send one signal, it will activate all the muscle fibers that innervates. So the fine motor control is going to be much worse, and that's also been shown in these type of studies. And then you have the last scenario here. You both see a size that the fibers they are reduced in size. So the muscle fibers itself they undergo atrophy, not brain atrophy, but muscle fiber atrophy. But also the number of fibers are reduced. The problem is that when you lose the number of fibers, you cannot regain it. When the muscle fiber size goes down, you can regain it, partly, by doing exercise. So, but at the point when the numbers or the nerves are actually dead or away, then at least down at the peripheral stuff, you cannot really rebuild it. And the consequence is, to a large extent, that your motor unit size increases. So your fine motor control gets reduced. Yes?
Can it be interesting to do this in older rats?
Yes.
With EI?
Yeah, well, there's actually there's a lot of animal studies in aging research, trying to look into this stuff. But there's been no studies in the using the EAE model or other models of MS, and we're trying to find out a good way to look at that as a starting step, to see if these mechanisms are actually going on. But still, there's a step from these EAE models to the human body. But yes, that's on the table at least, I think, from my point of view. I don't know if, but yeah. But just to show you how, so this is more the theoretical stuff about the nerves affecting the muscle fibers. But if you look at actually whole body scans, this is where they have performed DEXA scans. So normally they use DEXA scans to target how the bones look, the bone mineral density, but you can also get a pretty good quantification of your muscle mass, or at least of your lean tissue mass. And the lean tissue mass is mostly built up by muscle mass. So in this study here, it's only females, 71 healthy controls, 71 MS patients, and they've divided them into those who are ambulatory and non-ambulatory. And what you can see here is that if you look at the fat-free mass, that's the healthy controls, this is the total MS, it's slightly reduced. But when you divide it into those who are ambulatory and those who are non-ambulatory, it is actually reduced by approximately 10%. And in this study here, they show that it is associated with the ESS score. It's pretty... I come from... My background is actually aging research, and I'm very, very surprised that not more studies has been looking into muscle atrophy in MS. Because if the central nervous system doesn't work, then your muscle mass and your muscle function will be reduced. So, but that's good for us, then we can try to target that. Then again, this is the same type of study, just in men. See exactly the same pattern. This is just divided into low EDSS, or at least below 5.5, and 6.0 and above, and you can see the same pattern. So it's the same principle, that you can actually see that the muscle mass deteriorates. And if you look at in the aging research, this is a classic thing to examine. This is just a picture of a male 24 years old, a male 66 years old, and a 66-year-old person as well. This middle-aged older person, I don't know how to target it, but this is a very sedentary person, this is a very active person. And you can see actually that the darkest area in here, that's the muscle tissue. The white, that's fat or connective tissue. I would rather be this person. But I think actually loss of muscle mass, that's a hallmark of aging, and that's termed sarcopenia. And this is just to show, this is another large-scale study from the US. In the US, they've done a lot of these large-scale studies, very good. There are some European studies as well, but I think actually, this is actually Italian. So, but they've scanned the calf muscle of 1,100 participants, ranging from 20 years up to 90 years. And this is the males. They have a higher initial level, probably due to the hormonal differences in men and women. And then the females also here. But a general pattern is that both men and women, they start to lose muscle mass around 60 years and above. Could be earlier, could be a little bit later. And this is just to show how, from the younger groups, it starts to loss by from 20 to 30, 2% down, 20 to 40, 5%, and so on. So it's reduced in the oldest group by 31% in the males and 15% in the females due to the initial level. So there's a lot of muscle atrophy going on with aging. And if you just move it a step further out, looking at the impairments or the neuromuscular function, that's how the brain, the nervous system actually activates, controls our muscles. We normally assess that by different ways. One obvious thing is to assess muscle strength. That could be isometric muscle strength, dynamic muscle strength, or what we term explosive muscle strength. That is rate of force development, or the ability to move fast while still trying to produce as much force as possible. It could also be muscle power and what we term muscle force control or force steadiness. I'm mostly just gonna focus on this one, but these are actually in the same direction. So we did this review, as Ulrik also showed before. This is in the age range in these studies are between 34 and 55 years old. So that's the mean ages of these studies that we included in this review study. So it's young to middle-aged MS patients. And we could see this pattern, as Ulrik showed as well. So the 100% is up here. In the lower extremity, it's reduced about 25%. But when you actually looked at the few studies that examined the explosive muscle strength, and the reason why I actually take out explosive muscle strength, that it relies highly on the nervous system to function optimally. So it relies in your ability to recruit as many motor units as possible and with the highest possible firing frequency. It looks like it's reduced by 50%, and we are trying to look into that furthermore, and we show exactly in that area actually. And then Ulrik mentioned that about the upper extremity. It looks like it's a little less affected compared to the lower extremity. So I will also say that muscle weakness is actually a hallmark of MS. And I think from my point of view, I think it's a little bit understated in the clinical world. That it should, probably not in your world, but at least in Denmark, when we talk with the different neurologists and so on, they sometimes oversee this, I think. And from my point of view, it's a very important element. In this review, we showed that it was associated with EDSS, not that clear, but I think more studies need to be done in that context. And then again, the same Italian study from before, this is the decline in muscle strength. Now it's not muscle mass, now it's muscle strength. It's also a hallmark of aging. Muscle weakness is also a hallmark of aging, and that's more termed dynapenia, or loss of ability to develop force. And this is the percentage losses in strength. And this is just to compare it with the loss in muscle mass. So it's a much bigger reduction in neuromuscular function versus the reduction in muscle mass. That means muscle mass cannot explain everything. And that's why in aging you talk a lot about other factors. Other neural, at least the neural system is viewed as a main area. And actually a very interesting study is they did a 5-year longitudinal study in the US, and they didn't observe any changes in muscle mass, but the muscle strength declined a lot. And actually even in people who gained muscle mass, they still lost muscle strength. So something else is also going on. So I think actually, from my point of view, I think actually the nervous system in aging research is also a little bit, it's easier to assess muscle mass. It's easier to quantify, but the nervous system is a little bit more delicate to examine. So it's a little bit the same principle, and this is the same study we did, the preliminary findings. In muscle strength, we can see the same pattern as with the EMG, but when you look at the MS patients, it's a more continuous decline. Yeah. So moving on to the last part here, the physical functional, how does all of these impairments in muscle strength, muscle power, or so on, how does that actually affect like mobility or other functional tasks? There is actually, I was able to locate this one study trying to actually look at aging in MS. And they looked at both motor and cognitive function. I'm just going to leave the cognitive part out. But what they could see is that they had these MS patients, a large group, healthy controls, a rather large group as well. And they actually were from 20 to 70 years old in age range. So they had a good possibility to actually examine this. What they could see is that this is the time 25-foot walk test. So the short distance walk, and this is the 9-hole peg test, an upper body motor function assessment. They could see this is the change in the healthy controls. This is a change in the MS. So as the age increased, there was this linear deterioration in the walking function in MS, but also in the hand or upper body function in MS. But I think I just noted one thing about this study. It's not a linear decline. It's not a linear decline. I don't think there are any aging studies showing a linear decline. It's a curvy linear decline. So that I think that's because it's easier to use a statistical model where you force some sort of a linear system into it. So they did the appropriate statistical analysis to some extent, but it's more, it's not this linear perspective. It's more something like this, So at some point in time, the deterioration starts to accelerate. So this is a usual walking speed study from the US, 1,500 participants. Again, you see a large difference in patients. So walking speed here on the axis here, and you can see again men and women. In this case, the men are a little bit better than the women. No, there's no difference there's no gender differences in these elements here. So you see this biphasic or at least non-linear deterioration. We have some preliminary findings as well. We're actually trying to compare a data set we have with more, normalized or normal values from the literature. The blue bars, that's 6-minute walk test distance. The blue bars are healthy controls. The red bars are MS patients. What is very difficult to see, but there is actually a group difference in the pattern of development from young to the 70-year age group. And this is more the percentage decline. So what we could actually see in this data set, we can actually see that there's a much more increased deterioration or decline in gait speed or in 6-minute walk distance, in this case here, in MS patients. So it looks like there is an accelerated decline. And this just states that it is a nonlinear or biphasic. And I think that is the case. So just to sum it up, when we look at the limitations and so on down here, well, also in the disability case, this is probably, the blue line is probably the development in the healthy population. The MS population is a little bit more difficult because it's very different how they develop over time. You could have this relapse-remitting course where you start to go down and having disabilities or having limitations. But in a healthy population, it's much later in life that you actually start to experience limitations or disability. So yes, aging do cause a synergistic deleterious effect. But you can also say maybe, because it's still based on limited evidence. And we haven't actually taken into account the extra and intra-individual factors, and in particular the deconditioning or sedentary lifestyle. That looks like it accumulates as you grow older with the MS or as the disease actually evolves. So I think that's one complex thing you need to detangle from each other. So the perspective is that, along with what Ulrik actually said, that I would definitely trying to do exercise therapy that are specifically targeted towards the pathology. What Ulrik stated a little bit about brain volume and so on, but also about targeting impairments. I would say I call this here and now intervention. There is a group of older MS patients that needs a here and now intervention, because that's how it is right now. The ideal situation would be that 40 years ago or 60 years ago we could have started training them, but that's not possible right now. So I think what could be the case if you start, like if you look at this curve here, you start here and now intervention, it's possible to do something like this. It may look like just a slight improvement, but it could have a huge impact on daily life. They're not going to be like the healthy controls. That would be ideal, but I don't think that's possible to do. And then of course it could be power training. We showed in older individuals from 75 to almost 100 years old who were mobility limited, who could have a 6-minute walk test about 280 meters. It was possible to actually improve that, and it was associated with adaptations in the nervous system. And then, of course, the ideal intervention, that's actually the study Ulrik referred to that we are currently doing, or the Morten Riemensneider is currently doing, that you would actually start to exercise as early as possible, trying to, maintain or preserve the nervous system and the muscular system as good as possible. And that could be something like this, then, we're not sure that MS is disappearing. We don't think so, but it could be reduced in the extent. So, in that context, if you want to preserve the nervous system the best way, I would definitely recommend resistance training. Based on all other areas of research, it's shown to be the most efficient compared to aerobic exercise. I'm not saying aerobic exercise shouldn't be done. I'm just saying that in terms of targeting the nervous system, resistance training, heavy resistance training, explosive resistance training, highly efficient. And it's likely also the case in older MS patients. So yeah, thank you for your attention and yeah.
Tack så mycket Lars. Fantastisk presentation. En liten reflektion om det.